left. Four classes left, right? Is that right? Yes. We're not going to do classes on the very last week of the Monday of exam week, which is ridiculous, to give you information there. We actually do the therapy part, we actually have exams on Monday. We were certainly trying to spread them out over that week. So we have 2 weeks of classes, Monday, Wednesday. The Monday after we will not do classes. The exam is on what? Wednesday? Okay. Wednesday final. And that will comprise, what, 22% I think, of the final grade. For the PTs, there is a comprehensive final exam. Remember, like typically, that exam will be questions from every single topic you've had so far in your PT career. And mimic the board's exam. 5% of your grade for the PTs is on that. The OTs, you don't have a comprehensive final, so what I'll do is I'll put those 25 or so multiple choice questions onto the regular final exam on the end of it or whatever, and you know as much time as you want to take that. So you have plenty of time to take that exam. The final exam is, we've got a 2-hour block. Last exam most people finished in at least 45 minutes. So the final exam will be exactly the same as the previous exam, essentially same format. Technically comprehensive. I can ask you anything on the whole semester, but obviously the majority of those questions are going to run the new material. However, the comprehensive final, the PT exam, and the bit I'll add to the OT exam is much more comprehensive. That's the whole semester. That's for any material or you've had throughout the whole semester. We'll go over the exam for the last question.
Those 25, is it just multiple choice or
yes.
both?
Yes. In the comprehensive final of the PT, every faculty member submits 30 or so, 25 or so multiple choice questions to the big exam they take at the end. That's to mimic the boards. The boards is a multiple choice exam. So that will be all multiple choice, yeah. And your final itself will be a majority of multiple choice, but the really short answer just like this exam. Fair enough? We'll start, half an hour, 40 minutes early, 45 minutes, and we'll go over the exam. I think you'll find people make some silly mistakes in some places. There's some kids read the question and gave me a emoji versus sensory or something like this. Then we'll go over that at the end. Before that, we're going to just hopefully finish off the blood flow, and then maybe if we have time, we'll start the autonomic nervous system. The autonomic nervous system is a mess, I'm afraid. It's very complex and very weird. Like the rest of the stuff, which is very simple. Okay, so remember, two arteries go into the brain, internal carotids and vertebral arteries. Vertebral arteries go up the transverse foramen. They join to form the basilar artery. Let's come to that. Basilar artery goes into the foramen magnum to get into the brain. The hole in it, little bone, that hole. Some people occasionally don't have one of these vertebral arteries. Sometimes they're very thin, sometimes they're very thick, whatever. There's a lot of anatomical variation in vertebral arteries. This can be a problem in many vertebral arteries. Some vertebral arteries is dissection, where you basically get the wall peels off and the blood gets in behind it, forms a clot, forms atherosclerosis, plaque buildup, whatever, and you can have this vertebral artery dissection. A big issue if you're doing neck treatment, particularly some kind of mobilization or manipulation of a neck. We have to watch out for that, and these are the things to look out for if the patient presents with these symptoms prior to your treatment. You better watch out and seriously consider doing a neck mobilization. Let's get to this. So the two arteries, vertebral arteries, come up, they join to form the basilar. Just before they join to form the basilar, they give off anterior and posterior spinal arteries and the posterior inferior cerebellar artery. It then becomes the basilar artery, goes up the ventral brainstem, that the basilar artery ends by dividing into the posterior cerebral arteries. Before it gets to the posterior cerebral artery, the basilar artery gives off two more cerebellar arteries, the anterior inferior and the superior cerebellar artery. Cerebellum, obviously, so you need to know if you have a lesion to these, what sign and symptoms, what does cerebellum do, what are classic signs and symptoms of a cerebellar lesion versus a cerebral lesion. Okay? Internal auditory artery is also given off the basilar artery. This is what goes to the vestibular system, vestibular apparatus. So again, occlusion of this artery will cause vestibular symptoms. That's why you get your vestibular and vertebral artery test. When you do this neck twisting test, hyperextension and side rotation, you're closing down the vertebral arteries, or one of them anyway, which feed the internal artery with blood, and therefore if you suppress that, prevent blood getting to the vestibular apparatus, you see nystagmus, etc., etc. Okay? Posterior cerebral artery, this area here, on the inside of the brain, on the medial aspect, and this area here on the outside of the lobe, the posterior lobe. Calcium artery, remember where that goes? That comes off the posterior cerebral artery. This, of course, goes to the visual cortex. Left and right visual cortices. You know what symptoms you'll see if you get a left calcium branch stroke or something like that. The carotids come off the common carotid, where the common carotid splits roughly at the angle of the mandible, where we find the carotid sinus. There's arteries given off that. The external carotid ends up dividing the superficial temple and this maxillary artery here. And we mentioned before the important branch coming off that maxillary is the middle meningeal artery. We'll talk about that a little bit later in epidural hematomas. Okay, the carotids. And before they get up to the brain itself, or get right into the brain, they give off the ophthalmic artery here, and left and right going to the eyeball. So you're going to see, if one of those gets a chunk of plaque in, a complete lesion, a loss of blood flow to the left eye, the right eye, whatever, you're going to see blindness in the left eye or blindness in the right eye. The right eye anopsia, the whole of that circle will be shaded in, of course. The whole eye is gone. The internal carotids get into the brain to form a lacerum, that little hole in the sphenoid bone, and then here they are coming into this big circle here, of course, circle of Willis, we'll go to that in a minute. So the two major arteries coming off the internal carotid, so the internal carotid, we're looking up underneath the brain here, these pipes have been cut here and here, so the major arteries arising from the internal carotid are the middle cerebral, which is the largest one, and then the anterior cerebral, which is smaller, going front way, forwards. Okay? The anterior cerebral goes forwards through the longitudinal fissure and supplies the insides of the hemispheres. You see it there going through. Okay? And it peels out onto the edges of the hemispheres like this. So this would be a slice in the middle of the brain, all this area, and then this overlaps out onto the edge of the surface of the brain like this. Okay, remember the arrangement of your motor and sensory cortices on the brain here. Okay, that's basically all we talked about. I forgot to mention one perhaps important branch of the anterior cerebral. There's a big important branch that goes around the corpus callosum that comes off the anterior cerebral. I'll find a picture of it now. this is the anterior cerebral artery coming forward, and this big artery goes around the outer border of the corpus callosum. A lot of arteries branch off that one. That is called the pericallosal artery, around the corpus callosum. That's one of the major arteries that leads back deep within the longitudinal fissure on the top of the corpus callosum, where the two brains join, halves of the brain join, and that tributaries come off that to supply the inside of the brain. Okay, let's look a little bit more, a couple more points on the middle cerebral artery. The largest of the arteries supplying blood to the brain. That goes out away, laterally, away from the internal carotids, goes through, comes out, emerges out of the lateral sulcus. The lateral sulcus runs between the temporal lobes and the lobes above. It's going to emerge onto the surface of the brain and supply the whole outside of the brain, this big white chunk here. That's the middle cerebral artery. So the largest part of the brain supply, most of the brain, has more territory than the other artery. There's three important arteries we can locate here that directly supply the precentral and postcentral gyrus. Right down the central sulcus, and the central sulcus separates which two lobes of the brain? Frontal and parietal, okay? So there's a sulcal artery right there that goes right down the central sulcus. Okay? And either side of that, the precentral and postcentral gyrus, there are precentral and postcentral sulcal arteries. The postcentral sulcal artery here, and this is the precentral sulcal artery here. So, in other words, the precentral gyrus, what's on the precentral gyrus? Monocortex is supplied by the precentral sulcal artery and the sulcal artery. Branches coming off those supply that precentral, that motor cortex. The sensory cortex on the postcentral gyrus is supplied by the sulcal artery and the postcentral sulcal artery. So those are really important arteries to have blood going through them, obviously. Okay? If I got a stroke in one of those, let's say in the precentral sulcal artery, on the left-hand side, what signs and symptoms would you see in your patient? I've got a precentral sulcal artery stroke on my left-hand side, like this hemisphere is shown here. What signs and symptoms would you see? Would they be upper motor neuron or lower motor neuron? Upper motor neuron. What else can you say? So all things like Babinski sign, etc., etc. Would they be primarily legs, arms, face, hands, what? Would it be upper extremity or lower extremity? Upper extremity. Remember where the face and the hands and the upper extremity is on that motor cortex, right? That little man with his feet hanging in the edge. You can see the arteries on the top here. So look at this one here. The feet, remember, is in the crack. The feet are supplied by which artery? This one here. Anterior cerebral, isn't it? The anterior cerebral. That's where his feet are supplied by. This is where his hands and his upper extremity and his face are supplied by here. Okay? Okay, let's look at this mess. So, the middle cerebral, anterior cerebral, posterior cerebral arteries all join up. They're all anastomoses. So there are links between all those arteries. And this is known as the circle of Willis, after Thomas Willis. He was a 17th century English anatomist. So, they are joined. So theoretically, blood, if one of these parts of the circle is blocked, blood can go round the other way to get to all the arteries concerned. So let's look at what happens again. So, vertebral arteries come up here, join the bacilla. They eventually end up by splitting into the posterior cerebral arteries. However, there are these little branches here called posterior communicating arteries. The posterior communicating arteries join the posterior cerebral to the middle cerebral. So in essence, you're joining vertebral blood to internal carotid blood by those connections. Okay? You can also see that the two anterior cerebral arteries going forward into the longitudinal fissure have a little cross piece here that joins left and right anterior cerebral arteries. That's called the anterior communicating artery. So because of our anterior and posterior communicating arteries, there in essence is a circle here, all the way around. I can go round and round this circuit, joining all those arteries together. Posterior and anterior communicating arteries make up or help form this whole circle called the circle of Willis. And this allows blood to flow around the left side if there's a blockage in the right hand side. But that would only occur if you get a very slow atherosclerosis in one of these arteries. If you get a sudden occlusion, you're not getting enough blood around the other way to actually compensate for it. But if it happens slowly, you can get this collateral circulation going around the other side of the circle to bypass that lesion. Now, the circle of Willis is very, very common site of aneurysm. Aneurysms are little swellings, little balloons that pop out on the side of one of the blood vessels. Because, why would this be a common site for aneurysms more than anywhere else? Two reasons. Well, you've got all these big arteries, internal carotid, bacilla, whatever you want to call them, all pouring a lot of blood into a very small area. Okay? And what happens, these big arteries suddenly go into a small artery, like these anterior cerebral or communicating arteries. Okay? So you get a lot of high volume of blood suddenly hitting a small artery. That's like on a bike inner tube. It balloons out, the pressure bubbles out in one of these small arteries. So you get many, many places where you'll see aneurysms like these. These are sometimes called berry aneurysms, little berries sort of thing, blackberries attached to the circle of Willis. The other reason you'll see many aneurysms, there's a dissection of them, occurring here, is because you have sharp bends in the arteries. It's like a river. A powerful river going in a straight line and suddenly has to take a 90-degree bend, it's going to blow out the wall on the far side of the river. So if you've got a lot of blood pressure coming along and it suddenly hits a 90-degree bend, you'll see these little balloons occurring. Because the pressure has to, the blood has to take a sharp left, so it wants to go straight on. So it pushes through the wall and makes a berry aneurysm like shown here. These are percentages of places you'll see these berry aneurysms. Here is a berry aneurysm on the circle of Willis that's popped. And here's the bacillar artery. Here's the aneurysm that's popped. Okay, so very common site for berry aneurysms, circle of Willis. And remember what's just there, right next to the circle of Willis. Let me try to picture that. This is where the optic chiasma is, remember. The internal carotid. So there's the optic chiasma, right there. The internal carotid is coming right alongside of it. And right here is that pituitary gland. It's a really important place there. That's where we get some of our visual deficits, remember. The other part about the circle of Willis, this area is a very, very frequent site of strokes. Other than aneurysms, bleeds and plaque build-up and embolotic strokes. Okay? So a stroke, rather than an aneurysm here, is a little bit of fat, or you can have a thrombotic or an embolytic stroke. We'll talk about those in a minute. So we get junk, clots, blood clots and or plaque or whatever getting caught in the circle of Willis, this area, because we have these big arteries, the basilar, vertebral, whatever, internal carotid, nice wide pipes. A little bit of plaque breaks off the heart, for example, and it can get up through these big arteries at no problem. But then it starts hitting these little tributaries, little fine lines here, these striate arteries. Okay, these striate arteries are very small, but they supply important places like the basal ganglia and the internal capsule. So they basically get clogged instantly. So the big piece of plaque can handle going through the big artery like internal carotid, but it gets sucked into one of the striate arteries and bang, the person has a stroke. Okay? Now these are very important arteries here because they supply these little striate arteries, sometimes called the arteries of stroke. And they supply, as you can see in this diagram, the internal capsule. So with little arteries coming off the circle of Willis in various places, directly supply a deep areas within the brain, particularly the basal ganglia and particularly the internal capsule. So for example, you can see probably the most important ones of these are known as the lateral striate group, or the lenticulostriate. These little side branches come off the middle cerebral artery, the lateral striate arteries, or lenticulostriate. And you can see what I've labelled here. They supply the genu, the knee, and the superior portions of the anterior posterior internal capsule limbs. Okay, so the lenticulostriate, they supply the knee and both the anterior and posterior limbs of the internal capsule. So a problem in that, a stroke in one of those, you're in a mess. Okay? The inferior posterior limb is supplied by this one here. It's the anterior choroidal artery. That again comes off the middle cerebral artery. It's one in green. The anterior choroidal artery supplies the inferior posterior limb of the internal capsule. And the last one we'll mention is called the medial striate artery. Okay, that comes off the anterior cerebral arteries, and that one supplies the inferior limb of the internal capsule. That is sometimes called Huebner's artery. So another name for the medial striate is Huebner's artery. Very commonplace of stroke. A special name that you get, Huebner's artery is very frequently clogged up. Huebner's artery or medial striate artery. And you can see them on this diagram here, where they're going, supplying you deep areas within the brain, internal capsule and thalamus, basic ganglia area. Very frequent site of strokes. So the first small arteries that come off the middle and anterior cerebral arteries. And because they supply the internal capsule, that's the bottleneck for all those fibers getting out of the brain, you're going to get basically hemiplegia, aren't you? You're going to get contralateral hemiplegia. You're going to get the whole side of the body if you get the whole of the internal capsule. Does that make sense? I'd rather a stroke on the motor cortex somewhere than in an internal capsule. Alright, let's look how we get the blood out of the brain. Look at the venous return. So we've got the blood in, the internal carotid, etc., etc. How do we get it out? Okay, many of the deep cerebral veins, so deep within the brain, they take the blood to the periphery of the brain. Okay, they go outwards and upwards, taking the blood away from the brain, and a lot of it's going to get dumped into the venous sinuses, which is the largest, of course, is that superior sagittal sinus. So we've got these sinuses, this big, huge sinus, which collects a lot of the blood down the center of the brain, down the longitudinal fissure. Okay? What also is dumped into there? CSF, that's cerebrospinal fluid gets into there. Okay? But a lot of our deep vessels come out of the brain, this is an example here, and dump their blood into the venous sinus. And those are known as bridging veins. Bridging veins take the blood from deep within the brain and dump it into the superior sagittal sinus. They bridge across the meninges. These, with age, these bridging veins, with age, get less resilient, less plasticky, less flexible. And mild trauma can rupture these. Okay, and this is what we'll talk about later, leads to a subdural hematoma beneath the dura. Okay, the bridging veins, the ruptured bridging vein can lead to a subdural hematoma. So we've got a lot of our blood anyway into the superior sagittal sinus. Where does it go then? It goes all the way back around through this longitudinal fissure, all the way down like this, right round between the brain, down into here. We'll see where it goes in a sec. We also have, deep within the brain, we have this inferior sagittal sinus. So right down near the corpus callosum, we have another major sinus that collects the blood. And you can see it in this picture here, it's also in this picture here. Okay? And that picture there. Okay? That goes back into the straight sinus. So the inferior sagittal sinus goes backwards and joins what's known as a straight sinus, or rectus sinus. That then meets up with the superior sagittal sinus right at the back of the head, on the bottom diagram here, what's known as the confluence of sinuses. There's a big cross there kind of thing. And this is in your textbook. It's not a very good diagram here, but the confluence of sinuses is this lump. It's not a lump, but it's a place where they join. So, superior sagittal sinus comes back around the head. The straight sinus comes out from inside the brain, and they join at the confluence of sinuses. One last named vein we should perhaps mention is the great cerebral vein here, or the vein of Galen, G-A-L-E-N. Is this one here. That picks up blood deep within the brain and brings it out to the straight sinus. The vein of Galen. This one here. Great vein of Galen it's called here. So that brings it to the straight sinus. Let's go back to the confluence of sinuses. So this is the top view. So the blood has come down to here, the confluence of sinuses, and then those veins, or that sinus, splits and goes left and right to form what's known as the transverse sinuses. If I get our blood out of our brain now, you can see it here. This bottom diagram is the best one, perhaps. So at the confluence of sinuses, two veins go left and right. And they're called the transverse sinuses. They go left and right between the cerebrum, the posterior lobe, and the cerebellum. They go right around the back of the head, or come right around the front, something, from the back, around between the cerebellum and the rest of the brain. The transverse sinuses. Okay, nearly out. They take those transverse sinuses take an S-shaped bend to get to the internal jugular veins. And that S-shaped bend is called the sigmoid sinus. Sigmoid S-shaped sinus. You can see it here. The sigmoid sinus. So then we're into the internal jugulars, and away we go, out of the head. So, superior sagittal sinus meets up with the inferior sagittal sinus and rectus sinus at the confluence of sinuses. They then split to form a transverse sinuses. They fold down into the sigmoid sinus to get to the jugulars, and they're out. There's lots of names of these various sinuses and vessels as that blood is gradually taken out of the brain.
Is straight and rectus the same?
Yes. Straight and rectus is that the same. Rectus sinus is the straight sinus, same thing. One of the last place perhaps I mentioned, one last critically important area is this cavernous sinus. A lot of blood collects at the cavernous sinus here. Okay. The reason why that's important, here it is. Here's the cavernous sinus. Because a lot of our cranial nerves are located right there. The cavernous sinus is a piece of behind the eyes where a lot of blood kind of converges. Cranials 3, 4, 5 and 6 are right there. So infections in the cavernous sinus can be quite a problem. I'll mention one other clinically relevant thing, which is not often remembered. This little thing here, it's nothing to do with brain, it's nothing to do with blood leaving the brain, but where our arches on top of the scalp, okay, some of them have little, what are called emissary veins that go through the skull itself. So a lot of our blood, not a lot, but some of our blood on our scalp, outside of the skull, actually goes through, drains through small holes in the skull to dump their blood into the dural sinus. And those little holes, or little veins that pierce the skull itself, are known as emissary veins. So they take blood from the outside of the skin, outside of the scalp, into the dural sinus. So what's the big deal about that? Infections. You can get infections from the skin going into the brain, in essence. If you get infections in your emissary veins, in the skin on the surface of the scalp, and this is a portal for getting infections into the brain from the scalp. Not a good thing to do. Okay, speaking of clinical lesions, let's quickly look at some strokes. Okay, I think it's like 800,000 strokes a year in America. A lot. And of those, 160,000 will die, but that leaves 640,000 folks remaining around with strokes. So 640,000 people per year will survive strokes. That leaves a lot of patients for us to see. There are many types of different types of stroke. Now the big push is to make, rather than calling a stroke, we should be calling it a brain attack. Just like a heart attack. Because people know if you have these symptoms, this means heart attack, get them to the ER immediately. People don't seem to do that with strokes, with brain attacks. So now you'll see big, signs all around hospitals, recognize signs and symptoms of a brain attack. Get them immediately to the ER, because that is crucial in the amount of time that the brain is deprived of blood. So things like, you should tell your parents, grandparents, whatever, that the key thing is a sudden numbness. Sudden numbness or weakness in the extremities. ER immediately. Especially if it's an ipsilateral issue, if it's one-sided issue. If you have sudden numbness, tingling in the extremities on one side, that's pretty indicative of patients having a stroke. Another sign would be trouble seeing, blurred vision, double vision, all of a sudden attack of blurred vision in one or both eyes. Sudden confusion or trouble speaking. Loss of balance, dizziness, loss of coordination, and sometimes a severe headache with no known cause, an unknown cause, or a sudden headache. Put any two or three of those together, or even just one of those signs and symptoms, that's pretty indicative of patients having a stroke. So if somebody complains of that, those people should be taken to the ER ASAP. Just like they're having a heart attack. You don't wait to see if their trouble speaking, improves. Those people need to get to, because we can treat these patients very quickly with some, like clot-busting meds to get rid of that. The longer they're deprived of the brain of blood, the worse the symptoms are going to be. So you definitely need to be able to recognize the signs of a stroke and get those people to see in a medical emergency as soon as possible. Speaking of types of stroke, cerebral vascular accidents, we can basically split up the types of stroke into two: ischemic and hemorrhagic strokes. Ischemic, of course, means in Greek means restriction, heme is blood, so loss of blood. Ischemic stroke is a stroke where there's loss of blood to a certain area due to either embolism or thrombose. Those are typical, most common things you'll see. Compare that to a hemorrhagic stroke, which is a bleeding stroke. So when an aneurysm is burst, for example, the blood pulls out and sits within a certain part of the brain. You've got blood there, but it's not getting exchanged using the arteries and veins, so it just basically pools there. There's no use whatsoever. It's got no O2 in it. That part of the brain dies. Okay. The difference between an embolotic and thrombotic stroke, an embolism is basically where there's something flowing, some foreign body, like a piece of plaque or even a blood clot from another part of the body, has flown, gone up through the arteries and is clogged, is stuck in the end of it, in a small artery. A chunk of plaque broken off the heart, for example. That's an embolotic stroke, an embolism. You can have an air embolism as well. A fat embolism, for example, a patient has a broken femur, a badly broken femur, or whatever, the radius, and a chunk of bone marrow, a bit of fat, comes out of the bone itself, gets in the blood, goes through the heart, and ends up clogging an artery in the brain somewhere. That would be a fat embolism, an embolic stroke from that. A thrombotic stroke is basically due to atherosclerosis, where the side wall of the artery gets clogged. A blood clot develops on the side wall, and it gradually gets thinner and thinner and thinner until you narrow that vessel completely and there's no blood going through it. Okay? I mentioned before about the people who had routine autopsies. I remember exactly what it was now. It's like if they looked at routine autopsies of people over the age of 50 years old. These people didn't die of a stroke. They looked at people over 50 years old. 40% of them, when they looked at the internal carotids or the vertebral arteries, 40% of asymptomatic people over the age of 50 had one of those vessels closed down 50%. So these people walking around, half the people basically walking around over 50 have one of their arteries shut down by 50% because of atherosclerosis, because of bad diet, lack of exercise. Those walls are building up with plaque all the time now. And you can die of completely different, nothing to do with it. These people didn't die of strokes, they just happened to do autopsies on these people, and those were what they could see on their arteries. Pretty scary stuff, really. A special type of ischemic stroke is a TIA, a transient ischemia attack, or recurrent cerebral ischemia. This is where you get small little embolisms caught in the blood in one of the vessels, and they get dislodged and carry on. Or you get vasospasms. The artery spasms, the smooth muscle wall spasms and shuts down for a few seconds. This could be seconds, it could be minutes, like mini strokes. Usually these are a sign of bad things to come. It might last a few minutes, it might last 5 minutes. A patient will suddenly sit there and pause and get dizzy, and then they're okay again. And they're a TIA, transient ischemia attack. They might collapse, they might fall over because of it quickly and it's gone. But it's usually a sign of worse things to come. The hemorrhagic strokes can be intracerebral or subarachnoid. Is it in the meninges, or is it actually within the brain itself? Most common cause of this is what, do you think? What's the most common cause of intracerebral hemorrhagic stroke? Hypertension. Too much blood pressure, essentially. Hypertension. High blood pressure. And basically, after exercise, or not even after exercise, is basically an aneurysm bursts somewhere and just spills blood everywhere. A serious issue. In a subarachnoid stroke, you'll see blood in the cerebrospinal fluid. Last thing we'll look at before we go there, epidural subdural hematomas. These aren't strokes of the brain tissue. They're not in the brain itself. An epidural versus a subdural hematoma. The epidural hematoma, remember, is where we get a bones fragment that will cut your middle meningeal artery, the epidural, upon the dura. Okay? So this blood pressure builds up and he starts pushing on the dura. Sometimes here it's called, you see, it's called an extradural hematoma. That's not common terminology. Epidural usually. So in other words, the blood pools between the bone and the dura mater. So it starts pushing on the dura mater. This is arterial blood, so it's high pressure blood coming out. Okay? These are your walk and die patients, or talk and die patients. These are people who have an injury, they have a car accident, they fall and hit their head skiing, they're completely lucid for a few hours. They're fine. I'm fine, they get discharged, like Natasha Richardson did a few years ago skiing. But what's happened, that blood is gradually pooling and pooling and pooling, pushing on the brain tissue. Here you can see it's pushing the middle cerebral, medial temporal lobe onto the brainstem. The pressure builds up, and all of a sudden, with gravity, etc., etc., it's pulling and pushing on the brainstem. Within an hour, they're dead. They've gone home after had this accident, banged their head, felt okay for the first 2-3 hours. Blood's building up, building up, building up, building up, and all of a sudden, presses on the vegetative functions of the brainstem, and they're dead. This is what happened to what's his face. Who's the bloke who did the Atkins? Yeah, Atkins, Mr. Atkins. The Atkins diet, you heard of him? He did that, what, lots of meat and no something or other. Eat all the fat you can and no carbohydrate. He fell over in New York on the ice walking down the pavement. Fell over, banged his head. Got up, well, I'm fine. A few hours later, he keels over dead. Because of an epidural hematoma. Pretty scary stuff because they seem fine. What you've got to get to, of course, is the ER, get a CT scan and you'll see his blood pooling and they go out and drain it quickly. So, and there's another CT scan, you see it here, pooling up here. And there it is. So they basically take a flap of the skull out and suck the heck out of that blood quick. Relieve the pressure, clamp off the artery. That's an epidural hematoma. You walk and die patients. They come into the clinic, bump my head, feel fine, or ER, discharge, go home, die an hour later.
Why don't they just do a CAT scan to make sure?
Well, I'm fine, doesn't hurt. Why spend $1,500 giving me a CAT scan when I'm fine now? Every time you bump your head, you're going to have a CAT scan now?
Hell yeah. It's worth that money.
I mean, seriously, that's the thing. Exactly, you know, you'll soon be broke if you spend, CAT scan and bang my head, you know. Yeah, exactly. Where do you draw the line? That's the stops. Particularly old age. This minute small bone fragment, cut the artery. Hardly feel anything. Fine. All my neurological signs are perfectly normal. But 2 hours later they're not. And that's when you need, Alright, let's stop there. We'll talk about subdural hematomas next class. Exam. Let's look at that exam and see why